Buongiorno a tutti dall'Italia. Good morning everybody from Italy. My name is AttilioCarraro. I'm with the Department of Biomedical Sciences at the University of Padua, where I am the co-head of the Health, Exercise and Sport Sciences Lab. First of all, let I thank very much the organizers of this global forum for the great opportunity they are offering. The title of today's presentation is No Health Without Mental Health, No Mental Health Without Physical Activity. The presentation is structured into two parts. In the first part, I will discuss some data on the mental health global burden of diseases and the role of exercise in the prevention and treatment of mental health disorders and diseases. In the second part, I will briefly introduce the results of a short-term educational counseling program aimed to motivate patients with depression to be more physically active. Health is education. Before being epidemiological data, clinical trials, drug discovery, health is education. And promoting active lifestyle in people with mental diseases is, first of all, an educational and a social challenge. Brock Kieson, a psychiatrist who was the first Director General of the World Health Organization, promoted in the 50s the notion that mental and physical health were strongly related. Kieson stated that without mental health there can be no true physical health. 60 years later, there is strong evidence highlighting the bidirectional relationship of mental illnesses, particularly depression and anxiety, with physical health outcomes. However, despite the number of papers and documents edited, health policies continue to lag behind the evidence in these regards. Mental, neurological and substance abuse constitute an heavy burden for global health. Worldwide, they constitute 13% of the global burden of diseases, surpassing both cardiovascular diseases and cancer. Depression is currently the third leading contributor to the global disease burden, and substance abuse accounts for more than 5% of this burden. By 2020, it is estimated that 1.5 million people will die each year of suicide, and the lifespan of people with severe mental illness is shorter compared to the general population. Many authors explore the causes for excess mortality in people with severe mental illness, individuating as the main risk factors sedentary living. People with severe mental disorders are more physically inactive compared to the general population. Muscle weakness, a reduction in muscle mass associated with poor aerobic activity and with poor fitness, leads to a worsening of walking ability in schizophrenic patients. Diabetes, the risk for type 2 diabetes is 2 or 3 times higher than in the general population. Cardiovascular diseases, unhealthy eating habits, metabolic syndrome. And you can note that all these causes are related to physical activity and to active lifestyle. It is important to consider that stigma and discrimination in relation to mental illnesses can have worse consequences than the condition themselves. Sedentary behavior and physical inactivity contributes to the intake of morbidity and health cost. So, if there can be no true physical health without mental health, is it possible to state that without physical activity there can be no true mental health? Scientific literature is showing increasing interest in the relationships between physical activity and mental health. Based on a crude search of Medline using the words physical activity and mental health plus year, 1st of January, end of December, the number of papers published on this topic in indexed journals increased of 167 times from 1980 to 2015. There is an urgent call for improving the quality of life of people with mental illnesses and for cost-effective treatment programs. Exercise can play a key role in the prevention and treatment of mental health disorders, and it can represent an excellent tool for coping with physical problems and comorbidities associated with mental diseases, and in particular with weight gain, metabolic syndrome, and the general health status. And now, let I move to the second part of the presentation, the description of a study to test the short-term effects of an educational counseling program on physical activity motivation among a group of patients with depression. I realized this study with my team at the Parco dei Tigli Psychiatric Hospital in the province of Padua in Italy, and in the picture you can see the beautiful green area where the hospital is. Patients with psychiatric diseases experience different barriers to exercise. Physical barriers, such as the side effects of medication, illness symptoms, and individuals' state of health, pain and fear generated by undertaking exercise. They can experience environmental barriers such as socioeconomic factors, transportation issues, time required for physical activity, and psychosocial and relational barriers. For example, social anxiety, stigma and discrimination, self-presentation concerns, and lack of motivation and initiative. Low motivation and lack of confidence have been reported as main barriers to engaging in physical activity, particularly by patients with depression. Social support and physical activity self-efficacy were shown to be facilitators of exercise participation and adherence in people with mental health diseases. It is well reported in the literature, and it is a basic assumption in professional practice that exercise prescription may not be sufficient to encourage and maintain physical activity. Intrinsic motivation, enjoyment, and the overcoming of barriers are key determinants of regular exercise participation. The aim of this study was to assess the short-term effects of the 4-week educational counseling program on physical activity motivation in a group of inpatients with clinical depression. 40 adults participated in the study. They were 13 men and 27 women with a mean age of 42 years. Participants were randomly assigned to an experimental group or to a control group. Both control and experimental groups receive the standard treatment offered by the hospital, consisting in psychopharmacological therapies, psychotherapeutic treatments, and 1 hour a day of group-based exercise specifically tailored to this population. Participants in the experimental group participated in an educational counseling on physical activity. This the educational counseling, was based on four main objectives related to positive attitudes: self-confidence, goal setting, and the learning of how to plan active behavior. A booklet on physical activity benefits, barriers, and facilitators was developed and used during the counseling. It consisted in 1 hour session, in 2 1-hour sessions per week for 4 consecutive weeks of intervention, based on focus group technique and involving small groups of 3 to 5 people each. Participants filled in a package of questionnaires at the beginning and at the end of an intervention, consisting of the situational motivation scale, the SIMS, the physical activity enjoyment scale, the PACES, and the decisional balance questionnaire, the DBQ. No significant differences were reported between groups at the baseline for any of the variables. And again, no significant differences on the investigated variables were found by gender, both at the baseline and after the intervention. As usual with this population, study retention was a problem. Dropout, despite the setting, hospitalization, we have a dropout of 20%, 21 patients in the control group and 11 in the experimental group. As you can see, significant associations were found between the decisional balance questionnaire, PACES, and the SIMS subscales, determining a satisfactory level of accordance among variables. All the variables improved in both groups in post versus pre scores. Due to time limitation, here it has been reported only descriptive statistics. Intrinsic motivation, as measured with SIMS, improved of 1.8% in the control group and 5.5% in the experimental group. Enjoyment in exercise improved 4.8% in the control group and 7.1% in the experimental group. And decisional balance improved 25% in the control group and 11% in the experimental group. This result is in the opposite direction compared to the previous ones, reflecting a more realistic perception on the efforts required to adopt active behavior. In conclusion, educational counseling seemed useful in promoting more positive attitudes to physical activity, and it seems a positive integration to standard treatments, including exercise practice. Participants in the experimental group were able to better recognize the effort requested for regularly engaging in physical activity. Further research is needed to assess the long-term effects of motivational strategies on patients' physical activity, and particularly after patients' discharge. What we need today is to study the effects of this kind of a program on the long term. And thank you very much for your attention, and see you soon in Ankara. Ciao!